And a very welcome to your very last lesson in this assessment of the fetal status using the cardiotachograph series. I'm Anna Nolte and I'm going to teach you the very last lesson called fetal hypoxia. We're going to talk about the abnormal contractions. We're going to talk about CTG guidelines, the figure guidelines and the NICE guidelines. We're going to talk about types of hypoxia, and we're going to talk about the management of hypoxia according to the figure guidelines, in general measures of intrauterine resuscitation. Now, just a few words about the guidelines, the figure guidelines and the NICE guidelines. These guidelines have been developed and they put the CTG patterns into different categories. According to the figure guidelines, a CTG pattern is normal or suspicious or pathological, while with the NICE guidelines, a pattern might be assuring, reassuring, non-reassuring, or abnormal. Now, these guidelines just help you to a very large extent to interpret the CTG graphs. It helps you to understand where the CTG graphs, where to put them into which category, and that also helps you to understand how to manage or not to manage them. Now, if we look at the figure guidelines, figure stands for Federation of International Gynecologists and Obstetricians, and these guidelines have been developed by them to interpret the intrapartum fetal heart patterns, and they've placed them in different categories. They've used the three characteristics of the fetal heart that we were talking about all the time, namely the baseline, the variability, and the decelerations. And they say these fetal heart patterns are normal if the baseline is between 110 and 160 beats per minute, the variability is between 5 and 25 beats per minute, and there are no repetitive decelerations. And we have said repetitive decelerations means decelerations with each and every, with at least 50% of all contractions. Or it's these fetal heart rate characteristics might be suspicious if at least one of them is not normal. So if just the fetal heart rate is not normal, or the fetal variability is not normal, or if they're not falling into this pathological category, we classify them as suspicious. Then pathological is when the fetal heart rate is less than 100 beats per minute, so it's bradycardia. When the variability is reduced or increased, or we have a sinusoidal pattern, or where we have repetitive late or prolonged decelerations, with repetitive mean with more than 50% of the contractions, and they last, these repetitive late or prolonged decelerations last for longer than 30 minutes, or if there's a reduced variability as well, for longer than 20 minutes. So it's either these repetitive late or prolonged decelerations or decelerations that's longer than 5 minutes. Now, the interpretation for these different categories are as follows. If the fetal heart rate falls in the normal category, it means that there are no signs of hypoxia or acidosis. If it's suspicious, there's a low probability of hypoxia or acidosis, and when it's falls in the pathological category, there's a high probability of hypoxia and acidosis. And then also regarding the management, in the normal group, obviously there's no intervention necessary. In the suspicious group, we can start with a correctable reversible to try and correct the reversible causes. So if the mother try and turn the mother on a side, for example, correct the hypotension if there's hypotension, etc., and see how the fetal heart rate reacts to that. And then also very important in the suspicious category is close monitoring to see how the fetal heart rate or any other characteristic reacts to the corrective measures, and see whether it improves or whether it doesn't improve. And then in this last category, as far as management is concerned, My apologies, my slide moved on from the previous slide before I was finished. The management of the last category, the pathological category on the FIGO guidelines, would be to expedite labor as soon as possible, and we will talk about that a little bit later on when we get to the management on the FIGO guidelines. Our next classification or CTG classification is the NICE guidelines, and the NICE guidelines have been developed by the National Institute for Health and Care Excellence. They are in the UK, and they have developed guidelines for about every possible aspect in health care. There are, for example, NICE guidelines on the management of first and second stage of labor, the third stage of labor, etc. Beg your pardon. So this is the guidelines on the characteristics of the CTG. They've also used the different characteristics of the fetal heart that we're talking about a lot, the baseline, the variability and the decelerations. And they have categorized them into normal or reassuring, non-reassuring and abnormal categories. A normal fetal heart rate would be between 100 and 160. The baseline variability would be 5 or more, and no or early decelerations in the deceleration category. And the non-reassuring category is a fetal heart rate of 160 to 180. In other words, a mild tachycardia, and then a baseline variability of less than 5 for 30 to 90 minutes to exclude the sleeping cycle. And then they have different categories of decelerations in their deceleration area to make this pattern a non-reassuring pattern. They say if there are variable decelerations where the baseline drop by 60 beats per minute or less and taking 60 seconds or less, so that's the 60-60 rule that we were talking about earlier. If they are present for over 90 minutes, so if there are variable decelerations for longer than 90 minutes, and if they occur with more than 50% of the contractions. Or where there's the other side of the 60-60 rule, where they are more than 60 beats per minute and taking longer than 60 seconds to recover, but they are only present for up to 30 minutes and they're occurring over 50% of the contractions. Or late decelerations for up to 30 minutes and they're occurring with up to 50% of the contractions. And then what make the categories abnormal is if the fetal heart rate is above 180 beats per minute or below 100 beats per minute, when there's less than 5 beats per minute variability for over 90 minutes, and then non-reassuring variable decelerations for 30 minutes or after you have started with conservative measures to treat them, and that would be intrauterine resuscitation. And in spite of intrauterine resuscitation, we still see non-reassuring variable decelerations. Or late decelerations that's also present for 30 minutes and they have also not improved with conservative measures. Or bradycardia, just long single prolonged deceleration for longer than 30 minutes. So here you can see they use the reassuring methods, and if that doesn't react to our conservative measures of intrauterine resuscitation and they keep on longer, they become abnormal. So if we look at the different types of hypoxia, first of all we get an acute hypoxia, or otherwise we get a gradual developing hypoxia. In the acute hypoxia, the name says it happens suddenly, and in the gradual developing hypoxia, it obviously means that it develops over a period of time. So here we get in the acute hypoxia, we get a sudden drop in the baseline, like what we've said in the previous lesson where we referred to the prolonged decelerations. We get one single prolonged deceleration where the acute hypoxia lasts for less than 3 minutes, and then recovers to a normal baseline. Say, for example, the mother was lying on her back and you suddenly realize, but here's a deceleration. Ask the mother to quickly turn on her side, and the acuteness and the hypoxia recovers very quickly. Or you get the prolonged deceleration that lasts for longer than 3 minutes, or it just keeps on a prolonged baseline bradycardia where it doesn't come back and it stays below 100 beats per minute for longer than 10 minutes. Then if we look at the different causes for acute hypoxia, we divide them in two different categories. A reversible category, where there are reversible causes, and that obviously says the moment that we reverse the cause, the acute hypoxia will recover or become right, or in the irreversible causes where the acute hypoxia will stay. Like, for example, in this case, is supine hypotension. If the mother was lying on her back and we turn her on her side, there's decreased pressure now on the vena cava inferior and the aorta. The blood return to the heart is recovered, and obviously the acute hypoxia as well. The same if there was hypotension due to an epidural that can be recovered quickly. The hypotension can be recovered, then obviously the acute hypoxia will also be recovering soon and become better. Vaginal examination is often associated with a supine hypotension where the mother is lying on her back, and also sometimes in the case of stimulation of the fetal head, and that will easily also disappear as the moment that the cause has been removed. Artificial rupture of membranes. In the case of artificial rupture in membranes, one must just make 100% sure that there's not a prolapse of the cord as well. And then in many of these cases, there might be an acute hypoxic period, and then which just disappears and fortunately comes right on its own without any real cause being identified. And then we have acute hypoxia, which is due to non-reversible causes. And it's usually been caused by some or other secondary intrapartum incident, which we also call a sentinel event. So we have this huge intrapartum incident, and secondary to that, we get the onset of hypoxia. And these are usually the so-called sentinel events, or the intrapartum events that cause these acute hypoxia, which is cord prolapse, placenta abruptio, previous caesarean scar rupture, and a sudden rupture of this scar, hyperstimulation of the uterus, and sudden maternal hypotension, again due to either epidural event that the maternal blood pressure suddenly falls. And this is an example of acute hypoxia, in this case due to a prolapse cord, and you can see here the decelerations and the very prolonged decelerations. In this case, the deceleration was more than 3 minutes long. Our second group of hypoxia is the gradually developing or evolving hypoxia, and this is the group that's most common. It develops over hours. We usually get a normal fetal heart, and then gradually we get that there are signs of fetal hypoxia that develops. Initially we might get some decelerations, and if followed by the disappearance of accelerations, because what happens now is the fetus tries to save energy by limiting the muscle activity. So the fetus is not moving anymore, and try and save as much as possible oxygen in the process. And we know that when the fetus moves, we often get accelerations, and in this case it doesn't happen. Or the decelerations just get deeper and wider, which are all signs for us that there is hypoxia. And then, as we have said now several times, that if this persists, we get the stimulation of the adrenal glands, which releases catecholamines, and catecholamines increase the fetal heart rate, so that the vital organs can now get as much as possible oxygen, while the other organs are not getting enough oxygen. We get vasoconstriction to the other non-vital organs. And then if the hypoxic insult persists, we also get a loss of baseline variability because there's now also not enough oxygen to the sympathetic and the parasympathetic system to interact with each other. Here is an example of tachycardia. You can see the fetal heart rate is here above 180 beats per minute, and there's very little variability. So here we have tachycardia together with a loss of variability. Now, there are different things that contribute to the gradual developing fetal hypoxia, and there are there are 7 key mechanisms that result in fetal hypoxia. The one is this reduced maternal oxygenation, and that seldomly happens. The mother usually has enough oxygen in her blood. This might happen when there's a heart defect, the mother has a heart defect, or in the case of vaginal a hemorrhage where the mother is bleeding and lose a lot of blood, and then obviously oxygenation as well. When there's reduced blood flow to the uterus for some or other reason, in which case often hemorrhages are some of the most important, or also in the case of sudden hypertension, episodes of sudden hypertension where there's a less blood flow to the heart, and because of that also to the uterus. Reduced perfusion of the placenta is a very common one. Like we've said every time when we discuss the uteroplacental exchange and the occlusion of the uterine arteries every time with a contraction. So if the labor goes on for a long time, too long contractions, too many contractions, etc. And this is going with the reduced flow between the placenta and the fetus are basically falling in the same category. When there's reduced oxygen carrying capacity in the fetus due to some or other congenital or other problems in the fetus itself, when there's increased oxygen utilization by the fetus also for some or other reasons where there is some pathology in the fetus, and then also increased fetal end organ sensitivity to the lack of oxygen. These last 3 is usually due to some or other pathology in the fetus. Now, how do we manage hypoxia based on the FIGO guidelines? Now, as we've said, in the case of a normal category, if the fetal heart rate falls under the normal category, we don't need to do anything because everything is normal. But if there is a suspicious trace, we evaluate the factors that might reduce the fetal oxygenation. For example, we check whether there's not signs of abruptio or prolapse of the cord or too long contractions or etc. We look at the stage and the progress of labor because that helps to a certain extent to determine how we're going to expedite labor. If the patient is fully dilated, it's easy to quickly expedite the labor and get the baby out. But if the cervix is not fully dilated, obviously we need to go according to other different ways. Resuscitative measures can be initiated, which we will come to just now and see how we can resuscitate the fetus. This is unbelievably important to continue surveillance and frequent assessment with continuous CTG. One so often sees abnormal patterns of the CTG, and a decision has been taken that it's abnormal, but then the CTG monitoring is being stopped and there's no further CTG monitoring. So the moment that something is abnormal or suspicious, the fetal heart rate should continuously be measured so that one can see whether there is any reaction to the resuscitative measures or not, and according to that also will influence the decisions that's being taken. If the suspicious trace becomes normal later on, no further intervention is necessary except again to still continue the surveillance and frequent assessment with continuous CTG so that one can immediately see if something goes wrong again. And then obviously if it's persistent suspicious, it might progress to pathological traces, and then obviously the management becomes similar to the pathological traces. So how do we manage a pathological trace? Now, first of all, start with resuscitative measures, which we will come to just now. And then to improve the uteroplacental perfusion is the most important part of our intrauterine resuscitation measures. To get as much as possible oxygen in that uteroplacental area from the mother to the fetus. That's our main aim. And then if nothing happens and if the fetal heart rate doesn't improve, the next very important thing is to expedite delivery in either the form of a cesarean section or if the patient is fully dilated and the baby can be delivered quickly by doing that thing. Now, if we look at the in utero resuscitation, and these are the resuscitative measures according to the maternal guidelines, the maternity guidelines that's been developed by the Department of Health in South Africa, and these are the 2016 guidelines. Now, first of all, one must perform a vaginal examination to make 100% sure how far the cervix is dilated, because as we've said now previously, that will determine what kind of ways the labor is going to be expedited. And also to exclude cord prolapse and then manage the cord prolapse accordingly. Also to make sure that the mother has been repositioned. Remember in the very first lesson 3 we've said, the moment that there are abnormalities on a CTG graph, that you get decelerations, always immediately reposition the mother. The mother might just lie on her back, and that might be the big reason for these abnormalities. So reposition the mother on her left or her right side so that we get again as much as possible blood flow to the uterus and to this intrauterine placental area so that the fetus can get as much as possible blood. Then the administer oxygen. This is a little bit controversial because and there's evidence that show that oxygen can be not good for the fetus because and also not necessary because as we've said previously, it's seldomly the fetal compromise is seldomly due to maternal hypoxemia. So if it is due to maternal hypoxemia, for example in the case of a hemorrhage, then for sure the mother must get oxygen to get the oxygen levels in her blood as high as possible. But if the maternal blood oxygen levels are normal, it's not necessary to give fetal oxygen to the mother. Hyperoxemia to the fetus can also have adverse effects on the fetal retina, for example, like in the case of premature babies. And also, once the variability returns to normal, one can stop the oxygen, the supply of oxygen. Now, according to the guidelines, one should give oxygen, not too much oxygen, and also for a limited period to prevent these possible complications. So we give a 6 liter per minute via face mask for approximately 20 to 30 minutes, and hopefully in that time the variability will return to normal, and if it does not, then one needs to stop with the oxygen as well. Then, as I've said, the most important thing in our resuscitative measures is to improve the blood flow between the placenta and the fetus. So we give the mother intravenous fluid, and we give her a fluid bolus, so except if she's hypertensive, so to get her blood pressure, get the blood flow to the placenta, improve the blood flow to the placenta in order to get as much as possible oxygen to the fetus. And then in the case of uterine hyper and overstimulation, we should stop the cause of the hyperstimulation as quickly as possible. So we should stop the administration of oxytocin and prostaglandin if it is being administered. And if we can stop the prostaglandins, because sometimes the mother gets the prostaglandins orally or vaginally, and it might be absorbed vaginally already. If it's a tampon and one can remove the tampon still, it should be done. And if that can't be done and there's still strong contractions, tocilizers should be used. Tocolytic drugs should be used to stop the contractions or to at least decrease the contractions, and also in order to improve the blood flow in the placenta to the fetus. And then obviously this problem should be explained to the woman, because this can be quite an anxious period for the woman when she realizes that there's something wrong with the baby and she doesn't know exactly what is wrong. Just a few words on meconium staining of the liquor. There's always this thing that in the case of thin meconium, there's no special treatment. And then in the case of thick meconium, which is also being graded as grade 2 and 3, meconium is often associated with fetal distress, which is quite true. But what happens is when there is an episode of hypoxia, they usually the fetal gut is being stimulated to have more peristalsis, and that makes the meconium to be passed into the liquor. So meconium and the liquor tells you that at some stage there was hypoxia. We don't know exactly when. It's highly likely that it has been around recently if the meconium is still thick. And that's why it's so important to really monitor the fetus very well. My principle is that whenever there's meconium in the liquor, to always start monitoring the fetus continuously with a CTG, so that one can see whether this meconium stained liquor is associated with fetal distress now or not, or whether the fetal pattern is normal or not. And then the other very important aspect to remember when the fetus is being born during the delivery process, they might often aspirate some of the meconium in the trachea, and that causes pneumonia. So it's very important to suck this meconium if there is meconium and the possibility that the baby has aspirated them by using a laryngoscope. And that is the end of the CTG series. I really hope that you've enjoyed it. I really hope that you've learned something new. For those of you who are beginners in the CTG world, that you understand it now, that it enables you, or enabled you and still enables you to interpret CTGs now in a much better way. And for those of you who already had a lot of knowledge, that you just sharpened your knowledge in the interpretation of CTGs again. Okay, now is the time for your final quiz, and if you pass your final quiz, you will receive a certificate to say that you have completed this course successfully. So good luck with your quiz, and I really hope that all of you are going to pass it.